Good afternoon. My name is Jackie Walsh-Scanlon, and I am going to be doing a brief presentation on newborn respiratory distress syndrome, also called an RDS. This is a presentation that I've done for Youngstown State University, and it is for educational purposes only. So what is an RDS? This typically happens when a baby's lungs are not fully developed and cannot provide enough oxygen to the baby's lungs, which causes intense breathing difficulties. An RDS usually occurs when the baby's lungs have not produced enough what we call surfactant. This is a fluid that basically covers the lungs after a baby is born, makes it so it's easier for the infant to breathe, and reduces surface tension so that the lungs can open and close cohesively. If there's a deficiency of that product on the lungs, then it causes issues with breathing, ventilating, and oxygenating. NRDS is also referred to as infant respiratory distress syndrome, hyaline membrane disease, or surfactant deficiency lung disease. The picture on the left-hand side of the screen is a stereotypical picture that you would see of a neonate that does have RDS. There's patchy infiltrates, and there's bilateral sides of the lungs, there's a complete whiteout, which means that the baby's not able to ventilate well at all because there's no aeration in either of the lungs. That's all fluid buildup. So the picture on the right-hand side of the screen just goes over the basic pathophysiology of RDS. It also touches on some risk factors that are more prevalent for babies to develop RDS. For a couple examples would be intrapartum asphyxia. So if a baby has a stroke in utero, or there's something that's happening in utero before the baby is born, something wrong with the placenta or the umbilical cord, it causes the baby to be deprived of oxygen, they can develop RDS. If the baby is born via a C-section, a lot of times when women have vaginal deliveries, the babies go through the natural birth canal, and all of the fluids from being in the mother's sac are then pushed out of the lungs via the squeezing of going through the birth canal. When a C-section is performed, that fluid is not squeezed out appropriately, and so then that fluid can then deactivate the natural surfactant that the baby produces, which can cause RDS. Obviously, prematurity, if the lungs aren't fully developed, they're not able to ventilate or oxygenate appropriately, and then they also are deficient of that natural surfactant. Family disposition or severe acidosis. So if the mom had to have a crash C-section, had to get put under general anesthesia, had a placental abruption, any of those could cause severe acidosis if the baby needed any kind of resuscitation. So we have the circle of the pathophysiology. We have decreased surfactant, which then causes progressive atelectasis, which is basically just collapsing of the alveoli deep in the lung tissues, causes a disruption in the VQ or a VQ mismatch, which causes hypoventilation. You accumulate then the CO2. The baby starts retaining CO2, which causes the oxygenation to go down, which then forces the pH down. This can lead to hypotensive shock, pulmonary vasoconstriction or pulmonary hypertension, alveolar hyperperfusion, and then impaired cellular metabolism. So RDS is extremely dangerous, and if it's not corrected in a timely manner, it can ultimately lead to death or serious complications. Some symptoms of an RDS are often noticeable immediately after birth, and then they tend to worsen over the following few days. Examples could be blue lips, fingers or toes, central or peripheral cyanosis, rapid shallow breathing, or in the same token, the baby can be tachypnic, flaring of the nostrils, grunting, or retractions, what we call belly breathing. I'm going to show this quick video right here. This is just a little bit of an example of what you would see with a baby that's in respiratory distress. Now, this specific infant does have a VSD, so it does have a heart anomaly. So the blood flow through the heart is not adequately treating the baby. So this is why this baby is in respiratory distress, but it does have some of the stereotypical signs, symptoms of a baby that would be in respiratory distress. So as you can see, there's some substernal retractions. The baby is, nasal flaring, having difficulty breathing. You can look at this child and see that they are in severe respiratory distress. Just overall entire increased work of breathing. Very, very dangerous. So, diagnosis of RDS, there's several tests that can be used to diagnose RDS and rule out other possible causes. First and foremost, we need a physical examination. We need some kind of provider to look at this baby and see, hey, the work of breathing is increased, oxygenation has gone up. As far as requirements, there's something wrong. There's several blood tests that can be used to measure the amount of oxygen in the baby's blood and to check for an infection. So we could do a CRP to make sure that there's no infection happening. If that comes back normal, then we can use a capillary blood gas or an arterial blood gas to check the overall oxygenation and ventilation of the baby. That takes into account the pH, the PO2, and the CO2 of the baby, as well as looking at the bicarb and the base excess to get a general idea of how that baby is doing ventilating and oxygenating. A pulse ox can be applied to the baby to measure how much oxygen is in the blood. This is typically placed on the fingertip or the hand of the right hand, just so we can get a good pre-ductal measurement. And then a chest x-ray can be taken to look for distinctive cloudy appearance of the lungs. So treatment includes, if the symptoms are mild, they may only need a little bit of extra oxygenation. You typically in the neonatal ICU that I work at, we use something called bubble CPAP. It just adds, it uses a backflow of pressure and uses something called acetic acid. It's basically a hose hooked up to the acetic acid, and it you put Hudson prongs, which is what we use, into the nose, and it essentially works the same as patients that have obstructive sleep apnea. Um, and we usually start between pressures of 5 and 6. Put that in the baby's nose, and then that pressure opens up all the alveoli and just helps the baby through the period of RDS. If it's an older infant, a 35 plus weeker, we can try to use a nasal cannula, but sometimes babies that are surfactant deficient do need that positive pressure to keep the airways open while they get through the period that they need to get through. If symptoms are more severe, your baby will be attached to a breathing machine or a ventilator to either support or take over their breathing. It can also be given a artificial dose of surfactant, and that's usually given through a breathing tube. Evidence does suggest that early treatment within 2 hours of delivery is more beneficial than if it is delayed. So this picture on the left-hand side is obviously a premature infant, just based on the size, and it is intubated and hooked up to a ventilator. So that's just an example. The baby will also be given fluids and nutrition through a tube connected to a vein. And some babies with NRDS only need help breathing for a few days, and then they're solved, or some usually, ones, micropreemies that are born extremely mature may need support for weeks or even months. So what's the prognosis? Most babies with NRDS can be successfully treated, although they have a high risk of developing further problems later in life. Air leaks can occur from extremely high pressures used on ventilators. They also can develop internal bleeding. IVH is pretty prevalent in micro, preemie, and premature babies just from the movement outside of the uterus, tilting the head back to intubate, those kind of things. They can develop pulmonary hemorrhage because their alveoli are so fragile, they could hemorrhage. Or they could develop lung scarring from being on the ventilator for so long, is what we call BPD, which is bronchopulmonary dysplasia. Or they could have developmental disabilities, and these are all complications of an RDS. These are a couple of my references that I used to come up with the information from these slides. There's a ton of useful information on the internet that was very beneficial just in regards to newborn respiratory distress syndrome. If you have any questions, please reach out. Otherwise, I hope you enjoyed my presentation. Have a good day.